I'm going to be presenting on the Safety A intervention. It's formally called the Family Intervention for Suicide Prevention. Um, the organizations, I've been at UCLA for 4 years until this most recent summer. I still collaborate with Dr. Sarno. I still collaborate with many of my colleagues that I worked with at UCLA. Everything that I'm sharing today, you can learn more about at the ASAP Center website. I have that here for you all. It's www.asapnctsn.org. You'll see NCTSN in the name. We are an affiliate of the National Child Traumatic Stress Network. We were one of their funded sites as a Category 2 site where we disseminated Safety A along with other evidence-based approaches for youth suicide prevention. So we have lots of Safety A information on that website if you'd like to learn more. In terms of the hat that I currently wear, I moved to Philadelphia. I am an assistant professor at Thomas Jefferson University at a new suicide prevention center called the David Farber Aspire Center. I'm the clinical director there. I manage all of the clinical operations, and we are doing Safety A with everyone there. So I'm happy to come here to you today to talk about Safety A, both as someone who's done national trainings on Safety A, who's done research on Safety A, and who is doing Safety A clinically. Another hat that I wore related to Safety A is Safety A originally designed for youth ages 12 to 17. Right now, as we speak, we are actually running a PCORI-funded clinical trial on Safety A, actually for youth ages 15 to 24. So expanding that age range to young adults, it is being implemented in 5 different emergency departments across the country. So if you want to learn more about either the Aspire Center, the website is there. And if you want to learn more about the ASAP Center, I also have the website for you there. Let me go ahead and move on. So I don't have any disclosures to report, fortunately. I love to set a good agenda. I'm a CBT, cognitive behavioral therapy person at heart. So to set our agenda for today, I'm going to give you a little overview of the research supporting Safety A. The intervention is designed to address time with the youth, time with the parent, time with the family all together. I do, of course, have a video of Safety A so we can see it in action, and we have time to wrap up and ask any questions. Something I do want to highlight about my presentation today is that Safety A is tremendously flexible in the amount of time that you can deliver this intervention. In the original ED application, it was originally designed for actually UCLA's emergency department. And there it could be done in maybe 10, 15 minutes, a little longer, and maybe 20 minutes, for example. But the question is, who's delivering it? In our PCORI-funded study, that really varies. At UCLA, for instance, we have medical residents, fellows delivering this intervention. At our site at Duke, we actually have their social workers delivering the intervention who have a longer chance to spend time with the family. So depending on who is delivering the intervention determines, of course, how much time you're going to be able to devote to the intervention. And so what I'm presenting today is the different components, the different pieces to inform that intervention. But what you'll see is that there's an overall kind of spirit and approach that's inherent to Safety A that culminates in a developmentally tailored safety plan. The design, the overview of Safety A is to link to care, to build trust, build faith in the provider who's delivering the intervention, so then able to effectively link to evidence-based care and follow the recommendations made in the emergency department. So let me talk about that a little bit. In order to kind of build that trust and that faith and that rapport with the family, it's very important for this to be operating through a trauma-informed lens. When we say trauma-informed lens in the context of Safety A, it's not just things like physical abuse, sexual abuse, the standard maybe things that we think of when we consider trauma. But this expands the lens of trauma, expands it to concepts such as psychological safety, resisting potential re-traumatization, recognizing that folks may have had traumatic experiences with in the emergency department, trying to find mental health services, calling 911 for a mental health crisis, the fear of being involuntarily committed. These are all pieces of the trauma-informed approach that Safety A addresses and really asks folks who are delivering the intervention to keep in mind as they work with families. So asking questions as we deliver this intervention is part of the safety A approach. So it's considering things as you're talking with the family. Is the youth feeling safe in the current environment? Do you need to prepare in some way to increase this likelihood of supportive interactions? Are there other individuals, other caregivers, other protective folks who need to be looped in to support the youth in staying safe in their suicide risk? So these are the factors that we're considering in this therapeutic assessment. And so let me talk about safety A, the data side of things. So as I mentioned, what safety A is, it's a therapeutic assessment. It's not therapy. It's not doing CBT or DBT in the emergency department. That's just not realistic. It's also not just an assessment. It's not just doing like the CSSRS or the ASQ. It's not just asking, risk factors, ideation, non-suicidal self-injury, that sort of thing. It's taking a broader approach at this so that the therapeutic dose is delivered from key elements of cognitive behavioral therapy and dialectical behavioral therapy, but it also gathers data. It gathers information to allow you, the provider, to make an assessment about next steps in terms of risk level, what level of care is needed. And it also gives you data to figure out what needs to happen in order to make sure this youth, this family, gets the appropriate level of evidence-based care. As I mentioned before, the key kind of drive behind safety A is linking to an appropriate level of care, effectively linking to outpatient treatment. That's where the empirical support is for safety A. It's a very brief intervention. It's a one-session intervention. It's not designed to make the depression and the suicidality go away. It's designed to increase protective processes within the family unit. It's designed to increase family support. It's designed to restrict access to lethal means, improve protective monitoring. It's designed to increase hope within the family that they're able to get care. They're able to keep their child safe. The youth is better able to understand the emotional fluctuations that occur through things like distress tolerance, DBT concepts as well. So the approach is not on, we're going to make the suicidality disappear because that's not realistic, but instead, how can we contain and manage the suicidality in a safe, family-focused approach? So here's my favorite slide because I love data. This is data from the 2011 paper, the original trial of safety A. This was in UCLA's emergency department. Citations at the bottom, it's Dr. Sarno, Jonas Sarno is the first author. And we're looking at, after 1 month, after youth who are presenting to the emergency department with suicidality, what that linkage to care looks like. So when a family presents to the emergency department, they get treatment as usual, or they get FISP, which is the Family Intervention for Suicide Prevention, which is safety A. And so we look at these different rates of the link to care. And of course, I want to highlight on the far left, FISP. The Family Intervention for Suicide Prevention, by 92% of the families who had linked to outpatient care after getting this intervention in the emergency department. If you look at the other bars, we see it's not as nice of a picture. It is tough. It is traumatic to present to the emergency department. It is a whirlwind, and families report that it is challenging and it's overwhelming. And so the Family Intervention for Suicide Prevention, Safety A, is designed to make this more manageable, and more manageable in a way that allows families to trust the provider's recommendations, get that rapport, so that they're able to then follow through with next steps and walk away with a robust safety plan in hand. That's the goal of Safety A. And so, as I mentioned, I'm going to split this up into time with the youth, time with the parent, time with the family all together. This can be mixed and matched per your kind of clinical guidance on what we need to prioritize, what we need to be sure to focus on during the time with the youth. But the main takeaway is actually the resource that's highlighted in the packet that you should all have. This is the heart of Safety A, the A, B, C, Ds of screening and managing suicide risk. I'm going to present components of the intervention that are designed to be kind of the tools in your toolkit as you bring this spirit to the assessment in the emergency department. The idea behind Safety A is that in this therapeutic interaction, this therapeutic assessment, we're assessing for suicide risk. This is still so much more than, again, delivering a PHQ-9, for example. These are tasks. These are questions. These are ways that we can ask specific things that give us information on the level of risk that a youth may be, the level of cohesion within the family, what the youth thinks and feels about their ability to go to caregivers for support is part of this assessment. B stands for build hope. The idea is that in this interaction, the youth is feeling that they can do other things than make a suicide attempt, engage in self-harm because of the conversation that you're having with them. This is part of building that safety plan, having a conversation about next steps, helping caregivers feel like they're able to get high quality care and know how to care for their child and keep their child safe. C is creating connections. Are they able to feel like they can trust you? They have a relationship with you after they leave the emergency department. Does the youth feel connected to the family unit? Do they feel connected to supports, extended family? These are pieces of what we're looking at. D is then developing that safety plan. Does the youth and the family feel like they're leaving today with a clear plan of what to do, and heaven forbid suicidality reemerges, a crisis emerges? How can they navigate that? And do they know about resources like 988, for example? Do they know about what to do in a worst case scenario? A crisis comes back. These are all parts of the ABCDs of screening and management of suicide risk. So when I present to you these pieces, I don't want it to feel like, oh my gosh, do I have to do all of these, Lucas? But instead, how can I use these to complement the ABCD approach? What feels like a natural fit to my own personal style? What feels like it can kind of complement my approach? That's my goal of what's being shared today. And so when I say A, assessment, it can mean, as you see, I have like 10 bullet points on the slide. I'm not going to list them all, but A can mean so many things. It can be, can you have the youth share strengths about themselves? Or are they so depressed that they're unable to list any positives about themselves or the family? Are you able to talk to them about their emotional escalation and they can understand how they got from, getting a bad grade in physics to making a suicide attempt? Are they able to describe that in a way that helps you to understand, oh, they can regulate their emotions, or no, it's just, it feels out of control? Can they identify people in their life that they can go to for support? Can they have a conversation with you about lethal means in the home, their access, their ability to stay safe? Are you able to engage the parent and the caregiver in a conversation that lets you know that they're there to support their child? They're able to link them to services and to care? Or is the answer no to everything I just said? Then that is an assessment that this is a family who may be at higher risk and may need a higher level of care. That is what I mean by the broad lens of assessment of suicidality. And this can look like so many things. This is feedback that we actually got from youth as we've used Safety A. Feedback has been, it's so helpful when asking directly about suicide. A provider who doesn't shy away from, are you having thoughts of killing yourself, destigmatizing this conversation, looking to the provider, feeling that this is not something to be kind of shied away from, and in fact is something that can be really helpful. It's not putting the thought into someone's head. It's instead maybe bringing up a question or a conversation that the youth has not felt comfortable having or bringing up on their own. Tasks that the provider can use to change the session rhythm, knowing that the emergency department is an overwhelming place. It can be a scary place for teens and for parents and families. Being able to start with a fairly innocuous question of, can you list for me, because I'm meeting you for the first time, things that you view are strengths that you like about yourself? Can I get to know you a little bit before I have to ask you about what brings you here? Can I spend some time getting to know you, 2-3 minutes, before I have to jump into some of my questions about, suicide and self-harm? That can catch folks off guard in a positive way. It can shift up their expectations of who you are and what the questions you're going to ask in a way that builds rapport, but also in a way that gives you data. Because I'll say it again, it's one thing to have a child who can say, oh yeah, the strength about me is I have many friends, I can go to my mom whenever I need to, versus someone who says, I can't think of anything. There's nothing good about me. I'm a burden on my family, on my friends. It's a very different clinical picture. And that's what I mean when that assessment can be different than, giving a CSSRS, for example. There are different ways to gather data in terms of severity of suicidality. There can be different ways about asking about the strengths, be hobbies. What would your friends say that they like about you? Think about a time when things are going better. These sorts of things, especially when youth are maybe a little resistant or just shy or nervous when engaging with you. The same is then can be done asking about the family system, who is there to support the youth, who is there to help the youth stay safe. Are they able to list folks in the family? Are they able to list the caregiver who's there in the waiting room with them? Or does that seem to be maybe a rupture in attachment? That's data for you to have. That's data for you to know that when we're going to discuss safety planning, who are we going to involve in the safety planning? Does the youth feel comfortable with that person? That's valuable information when you go through that critical step of stratifying risk level and deciding what next steps could look like. But I think my favorite piece of one of the tools in the toolkit of safety is the feelings thermometer, because this is a way to really structure the safety plan in that developmentally informed approach. And what I mean by that is you can try to get kids to, fill out a safety plan. There are ways to make it more kid friendly, but one way to do this in a way that still has the conversation and key points of interest, but also is a little bit more engaging and interactive, is making this as a feelings thermometer, an emotions thermometer, having anchors where the child can clearly say 0 to 10, my emotions are X, Y, and Z. 0 meaning I'm comfortable, I'm relaxed, things are good, all the way up to 10, which is I'm feeling incredibly stressed, overwhelmed, I'm having thoughts of suicide. These are anchors that allow you to determine how are they feeling right now, for example, in the emergency department. How did they feel when they were having thoughts of suicide all the way up to the suicide attempt? But these conversations, this information maps directly onto the safety plan. This is data that's going to literally be copied and pasted onto, the warning signs, what I can do to stay safe. And in fact, saves time and it presents this information in a way that is a little bit more approachable, especially for younger youth. And what this looks like is that it actually is a nice reminder to youth of what have things looked like when they were at a 0? Can I remember a time when things were comfortable? Was this last week or was this 2 years ago? That gives you data on that depression snapshot, that clinical snapshot. Are they always at that 8, 9, 10 range, or is that only due to specific triggers or specific scenarios that set them up to that crisis level? Are they able to understand the shift between a bad day that they're not having a great day to a day that they're now having thoughts about suicide and self-harm? That's valuable information to have. I usually call it the boiling point or the danger zone. That's time when strategy should be used from the safety plan to, instead of continuing going up towards that 10, start to go down towards that 0. These are conversations that allow you to understand, does a youth understand emotion regulation? Are they able to share with you what this escalation and de-escalation look like? Are they able to understand what these different anchors look like in different scenarios? And can they engage with you about how they're feeling now and what events looked like leading up to their visit to the emergency department? That allows you, and this is an example of a kind of a bare bones example. You can have this on your, yellow legal notepad. It's literally 1 through 10. And for younger kids, I'll do smiley faces. You can have the situations and the reactions to flesh out these different anchors. You can get a little fancy if you want. You can have more mapped out feelings, body signs, thoughts, behaviors, etc. This is a tool that I want folks to use again to complement and strengthen their current approach in the emergency department. As I mentioned, this is just a way to help youth to better discuss and have conversations about their emotional escalations. This is, though, preparing us for the main event of Safety A, which is the personal plan, the safety plan. And so you'll hear me say personal plan over safety plan because many youth I work with have had maybe challenging experiences with safety plans. They'll say, oh, that was handed to me when I was in the inpatient unit. I actually have 3 of them. I've never used any of them. And I usually say something along the lines of, oh, if you already have one, it's sitting in the trash. I bet I can guess what's on the safety plan. Is it going for a walk, listening to music, and watching Netflix? I usually get 2 out of 3. And the reason is that many of these youth have had really not collaborative experiences in creating a safety plan, so that they're kind of left out of the piece of saying what works for them, what's feasible for them, what is something they'd actually realistically implement. So having this as a more collaborative experience and a piece that is built off of their strengths, built off of the emotions thermometer, so it can highlight things that they have been telling you, and you can reflect back as, oh, you told me a strength of yours, you love to work out and play soccer. Can we maybe put on the safety plan that you can go for a run to regulate your emotions? You can go out into the backyard and, kick the soccer ball around, because we know this is already something that they shared is a strength, something that's important to them. And so this is the safety plan. We know the kind of standard format of warning signs, what I can do to stay safe, what I can think to stay safe, who I can talk to. We expand this a little bit with Safety A by including just a little some tips that have been helpful with youth, especially with youth identifying warning signs. We're taking that from the emotions thermometer. We want to be sure there's internal warning signs, things like heart beating fast, physiological warning signs, as well as external warning signs, things that parents or caregivers can notice. They're withdrawing, they're lashing out, things like that, behavioral warning signs. What I can do to stay safe, we want to again have categories. We want to have things activities that the youth can do by themselves, but also with others. Settings are something we should keep in mind. If there's especially suicidal at school where they don't have access to their phone versus at home, do we need to have different activities based on the setting, based on who they're with? What they can think to stay safe. Are these things that are tailored to the driving cognitions of suicidality? Or is this kind of, something generic, oh, things will get better one day? Or is it, I'll be 18 in 2 years and I'll be able to move out of the home because my home environment is so challenging. So the idea behind safety is to have this be very tailored and very specific to the youth's presentation. And then who I can talk to, the folks that the youth can go to, caregivers, support figures. I always get the question, what if they want to have a friend on their personal plan? The recommendation I have is maybe like a 5 or below on the emotions thermometer, appropriate to have a friend, but above that, it's not fair to their friend and also not fair to them to have someone who's not a protective adult for safety reasons. Then we get into the conversation of, are they actually going to use their safety plan? What are things that are going to get in the way of the safety plan, such as having access to means, having access to substance use, ongoing substance use? So when we bring these things up as things that could be barriers to safety, it's couched in safety. It's not don't do drugs because drugs are bad. It's maybe, smoking cannabis every day is going to get in the way of your ability to note your emotional temperature, your ability to remember to use your safety plan in a safe, helpful way. This is done one-on-one with the youth because there are many times when a youth may have access to something the caregiver does not know about. So it is worthwhile to spend a minute away from the caregiver to ask about items that may have been hidden or secured away from the parent's knowledge. And then we wrap up by making sure that they're able to feel that they can commit to the safety plan, follow the safety plan. And if not, that's an indication they may need a higher level of care. And so, again, I want to emphasize you do not need to do all pieces of this, especially if time is short in the emergency department. These are tools that are meant to inform the assessment, building hope, creating connections, and developing a safety plan that's tailored to the youth. So I have a video because I want to show you all what does this actually look like in real time. So let me go ahead and share my screen. And this is one of our collaborators, Dr. Michael Wilkes at UC Davis, and he's going to be role playing this with an actress. This is not a real patient who is role playing a youth in distress. This is in a primary care setting, but I feel that much of this can be also generalized to delivery in the emergency department.
We're going to go through an exercise called building a safety plan. I have a list we're going to create for you, and then we'll ask you to take a picture and I'll give you a copy, and it will be a resource that you can use. Okay. A couple of things I want to mention first is that it's really important to me and to the people that love you that you're safe. We're going to go through a bunch of questions, but I want to emphasize at the end of the day that as your primary care doctor, I'm available to you. I'm going to give you a number that you can call 24 hours a day, 7 days a week. Most of the time, I'll be available for you. If I'm not, somebody on my team will be available and they'll be able to help you just as well as I can. Okay. I'll also give you the number for a 24-hour hotline. Again, not staffed by people that have no experience. These are men and women that are trained. I've had patients who've used them in the past and have felt that they were lifesavers. Let's start. There are four types of areas that we're going to look at. The first we're going to call warning signs. And I want you to help me think through going back to last night and perhaps the time when you were cutting yourself, to think about what were the warning signs. How did you know you were sort of slipping downhill?
Well, I started getting really overwhelmed after I was at that party because the guys just were yelling and trying to fight, and I think that's what really just sent me like over the edge, was all the yelling and the fact that it was getting so aggressive. So I just started feeling really overwhelmed, and I felt like my anxiety was starting to really settle in. Like I was shaky, or like my heart was beating really fast kind of, and I just kind of felt like I started feeling like I was losing control of what the situation, like what was going on.
Okay, so it sounds like for whatever reason, yelling and loud voices and sort of anger are things that sort of trigger things. So that's important for you to recognize that those are situations that, for lots of reasons, that you'll have to think about, but they trigger bad feelings. Other things that might set you off.
Um, Really, I mean, if it's not like, if people aren't yelling, it's really just, I don't know, I guess anything that sets my anxiety off, I just get overwhelmed in the sense that I can't get what I'm feeling and I can't get my thoughts under control. And so it almost feels like I'm spiraling a little bit. But
So it's feeling anxious.
yeah.
So sometimes when people report they feel anxious, there are thoughts in their head, but sometimes there are what we call physiologic or body kinds of things. Some people feel sweating, some people feel their heart racing. You feel any of those things as warning signs that you might be anxious?
Definitely like the heart racing, and just like, I guess, an overall like slight shakiness is really what that is.
Okay, so what you've told me is that you feel this anxiousness sometimes early on. You feel your heart racing, maybe a little bit of tremor or shaking. I heard you say that the loud noises and anger sort of set you off. And so as you begin to think about moving into the future and what might be in front of you, I want you to be very aware that those are early signs that you can pick up that things are not going well. The next step is what you can do to stay safe. And we all have different things that sort of have a calming effect and put us in a more peaceful sort of Zen state. Do you have things like that for you?
Lately, not really. I mean,
Is there anything that you enjoy doing, or a place or music you enjoy listening to, or a physical activity you like doing?
music, definitely. I have like an old playlist I used to use while running because it's like super upbeat music, I guess I could listen to.
That's great. I mean, I think that there's lots of research that shows that music can both bring us down and lift us up. And if you've got a playlist specifically that you find uplifting. That's a great thing to be able to do. Other things that you enjoy or that put you in a peaceful place?
Um, I used to cook with my mom a lot. If I can think of like anything that like activity wise I would do, it's pretty much like with her, that's what we would do. We would just cook and maybe watch movies, stuff like that.
And why do you not do that anymore?
I honestly just over the last few months of feeling like this, I feel like we've just kind of I've definitely like disconnected. So we haven't really done it as much because I don't really think I haven't really been up to doing that.
Mm.
But
So if we could somehow get that connection back, it sounds like at least cooking and maybe other things, but at least cooking is something that would take your mind off of things and put you in a peaceful place with someone that you love.
yeah.
Okay, so in terms of things that can stay safe, we talked about the playlist, we talked about music, and we talked about sort of being with your mom and doing cooking. Let's move to the third category, which is things to think about. So we talked about things that you were doing. Are there things that put you in a peaceful place that are in your brain?
Not ones that I can think that I like have used already, but I guess like now I can try thinking of like aspirational type sayings, like I don't know, like to breathe, because sometimes I know I can get so overwhelmed, maybe I forget to breathe a little bit. So maybe just to breathe and melt to calm down,
Okay.
stuff like that.
So in the future, we can talk about whether there are meditation exercises, but now maybe just taking some time, quiet time and breathing in deeply. It sounds like you've tried that before and that's worked. Are there relationships that are positive that would put you in a good place that you can think about?
Yeah. I have my best friend Sophia that we lean on each other a lot. And so I know I can call her. I have my aunt Nikki that I can also call.
We'll get to that, the calling in a moment. Those are really important, and we'll remember Sophia and we'll remember Nikki. But I'm thinking more about thoughts. I mean, things that are peaceful thoughts, that a place you've been, someone you've been with, a dream that you have for the future.
I guess I don't know. I guess I can just like remind myself to be in the moment and to not let whatever's going on, like it's only whatever's going on is only happening, I guess, in that moment. So to remind myself that it'll pass.
Yeah, I think that's really important.
Yeah.
You know, that we all have ups and downs, and you know, sometimes the downs are longer than they should be, but to remind ourselves that they'll pass and things will turn positive. Sometimes it's hard to see that, but to force yourself to do that would be great. So we've talked about the breathing. We've talked about being in the moment. We've talked about convincing yourself that it's only for a specified period of time. Let's go to the last area, which is this idea of who you can call. You sort of jumped ahead there. So we've already got Nikki, your aunt Nikki, on the list, and we've already got Sophia, your friend. Are there other people? Tell me about mom.
I think I've just been too scared before to call her because I know she like worries so much already and I don't want to scare her.
Mhm.
But I know like we do have a good relationship and I know if I just stop being scared, I could open up to her. So I know that I can probably call her. I just have never really done it before.
Yeah,
But I think maybe I can do that now.
yeah. Just think how mom would feel if anything happened to you. I think she'd want to be there for you now and be able to help you.
Yeah, definitely.
A couple of things. So
I'm just going to pause there for the sake of time because I realize we are rapidly approaching 3 o'clock. So I just want to say one or two more things and I want to open it up for questions. So that is the time with the youth And then we also have time with the parent one-on-one. Very similar to time with the youth. We take a minute to set an agenda, orient them to what to expect, who you are, what their role is, through that trauma-informed lens, recognizing that parents who may be stressed or maybe a little upset is maybe in fact a trauma-informed or trauma response that is what you're experiencing, instead of, a parent who's trying to be difficult. That is part of that safety approach. We similarly ask the parent to list strengths about their youth, to reground them, recenter them, especially if things have been especially challenging that day or week or month. Going over, especially with the parent, how they can keep their child safe at home around things like psychoeducation on warning signs, taking this talk seriously, discussing lethal means restriction, the role of substance use, and how they can keep the child safe and using the safety plan. It's really designed as a way to complement the information that was covered in the youth session, so that they can then feel prepared and equipped to have these conversations all together at the end with the youth present as well. So just having a conversation about the importance of limiting access to means can really create the time needed for a youth's emotions to come down, for protective help to arrive, instead of their ability to act on a potentially lethal urge. A discussion on what that protective monitoring can look like, especially when lethal means restriction may be challenging to implement in the home, and then having a conversation around the parents' view on substance use at this time, around safety around suicide. Kind of a quick checklist that we have. Part of safety is number one is always guns, and then medications, other things that may be present in the home, and whether or not the adult is in a place to support their child in staying safe. And then finally, the last part of safety is everyone comes together, discusses, shares the strengths, is a really nice way to wrap up and have a very positive time to bond as a family, discuss ways that the safety plan can be implemented at home, any barriers or things that may get in the way, that commitment to follow the safety plan, that commitment to follow your recommendations as a provider in terms of next steps, and any questions they may have on linking to care. All right. We have about 2.5 minutes for questions. Does anyone have any questions on what
Dr.
was?
Has a question. And thank you. That was impressive. Lovely.
Thank you.
Go ahead, Chip.
Thanks for doing this, Lucas, especially. We know it's late East Coast time. That that was so clinically rich. And, I've known about safety aid, but to actually see it and hear you go into the details and kind of where it goes beyond the ASQ and the Columbia, which, is just a slightly different, or maybe not so slightly different emphasis. I guess my questions are the training level of who can do this in the ED. How long do you think it takes to pull off? I have to tell you that, much to my disappointment, I found myself in UCLA and Ronald Reagan's ED on Saturday night, and I actually saw, I don't think you were on the call earlier. I saw ED nurses, not kids, but assessing adults handcuffed to gurneys with LA City paramedics, basically adjacent to the waiting room doors to the ED, right in the first hallway where, exam room number 1 is. Not a very conducive environment. Yeah. And the third thing is, and I think I just saw something in one of your slides, is there a linkage between MI and implementing safety A?
Yeah, that's an awesome question.
That's 3, so I'll be quiet now.
I'll say this can definitely build upon MI, especially around the substance use components, especially in terms of that commitment to following care. It really follows the approach of, we spent, the last 10 minutes building the safety plan to help you to stay safe. Is this something that you feel is worthwhile to follow after you leave the ED today, and using those MI components to build on that motivation to stay safe? We also do the DBT pros and cons component, which is pros of maybe cutting and engaging in self-harm, the cons of cutting and engaging in self-harm, the pros of staying safe and following the safety plan, the cons. So being able to validate that there are in fact maybe pros to self-harm or getting ready for suicide in a way that the youth needs to let out and hear, but those are heavily outweighed by the pros of staying safe and linking to care effectively. Who can do it? We say an individual is a licensed mental health provider. It can be master's level provider, because as you see, this builds on clinical skills related to CBT and DBT that wouldn't really be fair to someone who doesn't have much clinical training and background. And then the other component that sounds like in many ways the opposite of a trauma-informed approach in terms of making someone feel psychologically safe with the, the handcuffs situation, though that may be in fact, the way that the ED is structured. But I think the safety A approach would be to, is there any way to help them feel empowered and safe to structure and navigate that environment, so the takeaways that they feel they can trust you, trust the recommendations that are being made despite this very uncomfortable and maybe traumatizing environment they're in.
Wonderful. Thank you so much, Lucas. Very much appreciated, especially at your time of the day.
No,
If
thank you
people
so much
wanna-
for the opportunity to be here.
If people want to learn more about Safety A for their ED, how can they do that?
They can reach out to me directly. They can reach out to the website, which is also me. It goes right to my email address, but I can give you my Jefferson email address right now.
That would be very helpful. Thank you so much.
Oh, I accidentally sent that right to Trevor. Sorry.
He knows where to send it. It'll be okay. Thank you.
Thank you so much, everyone.
Okay.